eventually. It did take me a long time to get settled into cardiac electrophysiology. I spent a lot of years doing research and other things, even hospitalist work, before I finally started going more directly into my career path. But I really enjoyed my years of doing research and even watching from afar the things that were going on at CVRCI. I didn't know that I wanted to be an electrophysiologist, especially when I was doing my master's work and when I was doing medical school and even by internal medicine, I knew that I wanted to be a cardiologist, but it was really when I met Pingshan Chen and started doing research with him that I saw just how interesting and wonderful it was to study arrhythmias. And that's when I really fell in love with it. And so we'll go through some of the things that we did together while I was at Indiana University and then what's gone on since then. So I want to start out with a patient. This is a made-up patient, but it's pretty typical for what we would see when I was at Cedars-Sinai, especially. So you have a 60-year-old male, and he has a history of coronary artery disease, and he's had CABG before, and he has systolic heart failure. And often when you get systolic heart failure, you get ICD placed, and so this patient did. And then what sometimes happens is their heart failure gets worse despite the best optimal kind of medical therapy that they can get. And they start having arrhythmias as they start declining. And they start getting shocked. And so in this case, the patient got shocked. He came into the emergency department. He was put on, he was interrogated on his device, and it clearly showed that he had a ventricular tachycardia that was treated with pacing to try to get him out of the ventricular tachycardia, and then he was shocked. So overnight, he was put on amiodarone drip, and he was put on a lidocaine drip, and you can start a procainamide drip also, but then you're pretty much on maximal medical therapy for getting rid of, suppressing these ventricular arrhythmias. And despite those measures, he continued to have 3 more shocks overnight. And so once you get to this point, you have limited options. And so I want to talk about one of the most successful neuromodulations that has been developed for arrhythmias. And that is, we will get into this later, but it turns out that you can do quite a bit of neuromodulation that will help this situation and get you into a more stable place so that you can either get this patient, if he's going to end up getting a transplant, then do that, or if you're going to end up doing a LVAD to get him stable enough for that kind of surgery. And sometimes you stabilize them enough that they're fine without. But neuromodulation has turned out to be the key for a lot of these patients of the autonomic nervous system, I mean. So I wanted to go more into the history of what's been done with neuromodulation of the autonomic nervous system for arrhythmias. It turned out that in the late 1800s, nearly 20th century, it was proposed to do removal of parts of the sympathetic nervous system so that people could have help with their angina. Now, they would take out what probably was part of the stellate ganglion. And when they would do this, many times the angina would improve. However, what they observed was that ventricular arrhythmias also were decreased by doing the sympathectomy. And that led to a lot of speculation as to the mechanism. And so We can, you can see that there are other people that, but then it started to be more studied. And so I want to talk to you about what are some of the, what is some of the pathophysiology between why a sympathectomy or neuromodulation might help arrhythmias. Then we'll talk about monitoring of the autonomic nervous system and seeing if that can help you to know what to do with neuromodulation. And then after you see patterns in the autonomic nervous system, what sort of neuromodulation you can do. And then we'll talk about two different rhythms that are most established for treating with neuromodulation. So in this slide, I like to show this because it just shows the intricate nature of the relationship between the nervous system and the cardiovascular system. And you can see that there's the white nerves are pretty much peripheral. The yellow nerves, sorry, are peripheral nerves. But as you look at these purple nerves and the green nerves, you can see that they're just completely interlaced along the cardiovascular system. And these go all the way down until you get to the heart. And I want to show you the next slide that these nerves go all the way down and create a network on the heart. And so these nerves are not only intricately related to the vasculature, but they're actually on the surface of the heart, making connections that have complex neural processing that influence the way that the muscle behaves. And so I show this just to sort of illustrate just the diversity of and the extent to which the nerves are being connected to the muscle tissue. And these, as I said, these nerves actually organize into centers, and we call them ganglion plexi. And there's several that are on the surface of the heart in the fat pads. And so one of the targets for during doing neuromodulation is actually trying to get into these fat pads and trying to do some sort of intervention. The nervous system, as it relates to the cardiovascular system, is divided into several centers and has several layers to it. There's the brainstem and the higher centers. There's the thoracic and spinal cord. There's the sympathetic chain, which have the stellate ganglion. And there's the intrinsic cardiac nervous system, which we looked at in the previous slide. And then we also have found that even modifying the sympathetic nerve activity in the renal nerves also affects cardiac arrhythmias, probably, most likely through feedback mechanisms. And one of my favorite things in electrical engineering was actually feedback systems. I really enjoyed those classes. And a lot of my master's research was also in control systems, biological control systems. And so this has been sort of my fascination throughout my career. And this slide is to show that there's actually different processing that happens in different centers of the autonomic nervous system. That there is afferent nerves that go to each of these three levels of the autonomic nervous system. And then there's efferent nerves that go back to these centers and then go back to the heart muscle and control how the heart muscle acts and how these different nerve centers react to different stresses. Wanted to point out arterial baroreceptors. We'll talk about those later too. That they have afferent control on feedback loops. So we know that there's several effects that are clearly clinical in that the autonomic nervous system has on the heart. And that is, it increases heart rate, it increases AV conduction when you stimulate the sympathetic nervous system. There are opposite effects when stimulating the parasympathetic nervous system. And there's also increased automaticity in different muscle cells. There's also an increase in re-entry. When you give some parasympathetic nervous system stimulation, you can also have increase in conduction time and also increase re-entry that helps to stimulate arrhythmias, or helps to set up conditions that are correct for arrhythmias. We know that supraventricular tachycardias are more increased with sympathetic nerve activity. The effects of antiarrhythmic drugs is less with sympathetic nerve activity increased. And with increase in sympathetic nerve activity, you can also have an increase in dispersion of repolarization, which also increases the chances for re-entry and for other arrhythmias. And then you have a decrease in the ventricular fibrillation threshold, and Takotsubo is also something that is well known to happen because of autonomic nervous system sympathetic activation. So here's several studies that have shown the effects of the sympathetic nervous system or in neurotransmitters of the sympathetic nervous system. It causes early after depolarizations and delayed after depolarizations in the muscle cells. It encourages reentry and automaticity, where you can see this is like a ventricular tachycardia pathway that's propagating the ventricular tachycardia. And these are encouraged in sympathetic nerve activity. There's also conduction velocity changes and activation propagation changes. There's also, as I mentioned before, dispersion of repolarization. On this, you can see the increase in dispersion of repolarization here from baseline to sympathetic stimulation. And you can see it's preferentially happening on, I think it's on this page, where you see that it's preferentially on the epicardial surface that you have this increase in decrease in repolarization, as opposed to the increase that happens at the endocardial surface. And so throughout the transmural layer of the muscle of the heart, you have an increase of that, of the gradient of how much repolarization is happening. And that is helpful for starting these ventricular arrhythmias. There's also nerve changes that happen in different diseases. The nerves will die out in infarction, but then they'll become hyperinnervated. And then in diabetes, actually, there's a lot of denervation, and sometimes you even have silent ischemia that may promote arrhythmias. So we also know that systolic heart failure makes some changes in the autonomic nervous system. And in this, I'm just illustrating, this is just an illustration to show that in systolic heart failure, we know that sympathetic nervous system activity is increased, and that there's likely a decrease in the parasympathetic nervous system activity. And this imbalance tends to be what encourages ventricular arrhythmias more. And this is done through afferent signaling. It's done through angiotensin II. It's done through its effects on renin and angiotensin and aldosterone. And there are also direct effects through the nerve activity. There's also cellular remodeling that happens with systolic heart failure that causes downregulation of beta-1 receptors and upregulation of beta-2 receptors. And so even with the same amount of sympathetic nervous system activity or the same amount of catecholamines that are circulating, there is a different kind of effect that it has on the failing heart. And so there's also an upregulation of slow conductance potassium channels, which also increases the dispersion of repolarization and encourages ventricular arrhythmias. And then what happens is that with stimulation by catecholamines, the beta-2 receptor activation can cause hypokalemia. And this hypokalemia can cause inhibition of the sodium-potassium pump. It causes a mishandling of calcium in the cell, and it causes action potential duration prolongation. It causes early after depolarizations. And this effect can sometimes cause a feedback loop and cause ventricular arrhythmias also. So there's two main ways that you can non-invasively monitor autonomic nervous system activity. And so we're going to talk about several ways that we can monitor autonomic nervous system activity, but the non-invasive ways, there's basically two. And the one is baroreflex sensitivity. With the baroreflex sensitivity, the sensitivity actually goes down with heart failure, meaning that the sympathetic nerve activity is probably increased and the parasympathetic nerve activity is probably decreased. And with heart rate variability, what you can see is that the slow variations are decreased when you have increased sympathetic nerve activity. There are invasive ways also to look at monitoring autonomic nerve activity. And I did a lot of that work with Dr. Chen, and we would put electrodes in dogs where we would put them in electrodes right in the fat pads where the ganglion plexi are. We would also wrap a coil around the vagus nerve to monitor that nerve activity, and we would also put an electrode on the stellate ganglion. And so through doing this, we could look at the relationship of the nerve activity and see its relationship with the arrhythmia. One other way that we found was that you can also put an electrode in the pharyngeal nerve, but there's also a less invasive way that has been developed by Dr. Chen over the years, in that they've seen many different disease states where they've been able to confirm increased sympathetic nerve activity by looking at subcutaneous nerve activity, which is putting an electrode, like doing an EKG and looking at nerve activity from very small signals in the surface of the skin of the chest. But in the dogs, what we did is we actually went into their skin and stuffed the electrode into their skin and monitored the electrical activity that way. And so this is an illustration of how there was an increase in stellate ganglion nerve activity that happened seconds before there was the onset of ventricular tachycardia in these heart failure dogs. And this was a consistent finding that happened before arrhythmias. What we also found is that there's not only an increase in the stellate ganglion activity, but there's also an increase in the skin sympathetic nerve activity. And we've been able to show that we can see enough of this nerve activity that we can monitor this without invasive electrodes. But again, see this increased nerve activity that's preceded by a few seconds to minutes before the VT starts. And you have a high degree that starts this episode here. And there are times when it's very quiet. And most of the time when you have quiet activity, there's not much like ventricular arrhythmias. But there are times when the myocardium is still adjusting to the conditions that it's under from increased stimulation, that it still has an induction of ventricular arrhythmias. And so this is another study where we did in dogs, where we looked at skin nerve activity compared to stellate ganglion nerve activity. And we were able to see that the stellate ganglion nerve activity and the subcutaneous skin nerve activity was very closely related, had a high correlation value. And in all the dogs, it was true that there was a high correlation. And when we looked at the signals, you could see that as the arrhythmia was getting started, there was an increase in nerve activity, and then the atrial tachycardia would start, and there would be a change in the, there would be a induction of arrhythmia. And what we also did in these dogs is we ablated the stellate ganglion. And we could see that as we ablated the stellate ganglion nerve activity, this was greatly decreased the nerve activity, of course, of the stellate ganglion, also greatly decreased the nerve activity of this subcutaneous nerve activity. And it's interesting that it was also because of unopposed sympathetic nerve activity, the vagal nerve activity also decreased. Or perhaps we we're recording some of the sympathetic fibers that are in the vagus nerve also. But anyway, there was a decrease also with cryoablation of the stellate ganglion. But what we found was there was 243 episodes of atrial tachycardia in dogs without the cryoablation. And those with the cryoablation, they had no episodes of atrial tachyarrhythmia. And so it sort of proved the point that if you get rid of that sympathetic nerve activity, you decreased a lot of the arrhythmias. So now we're going to talk about neuromodulation of arrhythmia. In general, there's neuromodulation you can do at the very top level of the autonomic nervous system. There's some that you can do at the spinal cord level. There's some that you can do at the sympathetic chain. That's part of the stellate ganglion is part of that system. And then you can also do interventions either intraoperatively, if you can get direct access to the intrinsic cardiac nervous system. You can do some interventions there. And then there's also renal denervation, and we'll talk about all of them. So first of all, we'll talk about neuromodulation that's been done for ventricular tachycardia and ventricular fibrillation. And most often, this kind of intervention is done for people that are similar to our patients we talked about at the beginning, who have basically they have ventricular, they have VT storm is what we call it. And when they have, within 24 hours, they have 3 or more shots from their defibrillator. And it seems that we're not gonna be able to stop it with medication. So in these circumstances, it was shown in a dog model that when you have lots of ventricular arrhythmias, that if you give thoracic, when you give spinal cord, so you can give thoracic anesthesia and you can stop ventricular arrhythmias. But in this study, it was actually we implanted a spinal cord stimulator. And I helped Dr. Lopshire implant a few of these spinal cord stimulators in these dogs. But basically, after giving the dogs spinal cord stimulator, they would give them an infarct, and then they would pace them. So they would go fast until they went into systolic heart failure. And then they would start having ventricular arrhythmias. The interesting finding in this case was that spinal cord stimulation improved the systolic function compared to those dogs that didn't have spinal cord stimulators or didn't have their spinal cord stimulator turned on. And so I wanted to show that the ejection fraction was normal at baseline, and they all went down after giving the infarct and pacing them fast. But when you got to 5 weeks, you had a dramatic improvement in the ejection fraction for those dogs that had spinal cord stimulation. And in a like manner, those dogs that had spinal cord stimulation had less spontaneous ventricular arrhythmias and had less of a percentage of events than those dogs that didn't have spinal cord stimulation. And this is a study that was done in follow-up to that in humans. And it was a small study, about 20 patients. They saw that maybe they could see some improvement in maybe symptomology, or with having a decrease in their NT-proBNP, which is a marker of how fluid overloaded someone is. But when it was repeated in a larger study, there was actually no difference between a control group and those that were implanted with a spinal cord stimulator. And so this was a disappointing result, but nevertheless, it helped us to understand how we might proceed as far as research in this area. As I said, you can also give thoracic epidural anesthesia. You make a lot of these ventricular arrhythmias or ICD shocks actually go down after giving them anesthesia in their spinal cord or an epidural. And then we come into what has become more established as our clinical practice in suppressing VT storm. In this study that was done at UCLA, they would give anesthetic transcutaneously to the area of the stellate ganglion. And in doing this, they could greatly reduce the ventricular arrhythmias without giving an epidural, keeping them tethered to the epidural, or another way to actually decrease ventricular arrhythmias is actually to intubate somebody and put them on general anesthesia. And so they were able to greatly help these patients to avoid having general anesthesia, being on a ventilator, by giving them transcutaneous injections. And so you can see the great decrease in the arrhythmia episodes and a great decrease in the shocks that the patients receive. And this is another reported study where also out of UCLA, where they were able to decrease the ICD shocks in a patient, not for VT storm, but in a long-term manner, if they went and resected the stellate ganglion. So they removed the stellate ganglion surgically. And in doing this, they were able to greatly decrease their ICD shocks. And there was a more so decrease if they had bilateral stellate ganglion removal. And then this is a similar graph showing similar result, in that if you do bilateral stellate ganglion resection, it's better than if you do just one side, which is, they usually did the left. But these patients under the curve were able to stay shock-free. There was also a study that looked at neuromodulation through non-invasive kind of means. In this case, a stimulator was put on the tragus of the earlobe. Oh, sorry, not on the earlobe. The earlobe is different. It's actually doesn't have any innervation and it's not connected to the vagus nerve, but the tragus is connected to the vagus nerve. And if you stimulate it, then you can get a vagal effect. And in doing this, they were able to improve function of these patients that were in heart failure and decrease ventricular arrhythmias. In a like manner, there was a decrease in VT, VF, and shocks when patients had renal sympathetic denervation. We think that the mechanism by which this happens is actually a feedback mechanism that works on higher centers of the brain, and then those higher centers have a downstream effect on the heart, which decrease these ventricular arrhythmias. But there's been a couple to several studies that have shown pretty consistent results with renal nerve denervation. And this is a second study. You can see these are the group one is the ones that had VT ablation. And the group two is those that had VT ablation plus renal nerve denervation. And you can see that there was a great decrease from 43 to 2. And even in those that had just the VT ablation, there was a decrease 35 to 12, but there was significant difference between the two groups when comparing their VT events, their ATP therapies, and also their shock therapies. ATP being pacing to try to pace someone out of ventricular arrhythmia. And so now we'll talk about different neuromodulation that can be done for atrial fibrillation. While I was in Indiana, we were also just finishing up some studies that showed that direct vagal nerve stimulation had an effect on atrial fibrillation and decreasing the burden and the duration of persistent atrial fibrillation in dogs that were paced chronically until they went into atrial fibrillation. And so in vagus nerve stimulation, you put an electrode on the vagus nerve, you put the generator down in the chest, like you might put the generator of a device like a pacemaker or defibrillator. And when you stimulate, you can have a decrease in the atrial fibrillation burden when you have the stimulation that's active as opposed to implanted but not turned on. You greatly decrease the episodes per day, and then these are in dogs again. And then the atrial tachycardia burden is also decreased when you have vagus nerve stimulation. So this is actually the tragus nerve stimulation for vagal nerve stimulation has also been studied in humans. And this came out just in, I think it was 2020, yes, where they showed that there was a pretty good effect on atrial fibrillation burden and events when you stimulate the tragus of the ear. And this is an example of what the unit might look like, and this is where you put the electrode. This is the sham. In all these studies, the sham is always put on the earlobe. And you can see in the patients that were not on tragus stimulation, their burden of atrial fibrillation actually increased over the 6 months that they were studied. And then those that were on the vagus nerve stimulation actually had it decrease. And they also showed some inflammatory marker decrease when they stimulated the tragus. We also think that there may be an effect on atrial fibrillation by ablating ganglion plexi that are on the outside of the heart. you can often ablate these even accidentally while doing a pulmonary vein isolation for atrial fibrillation therapy. And many times there have been several studies that have tried to figure out if you target them specifically after pulmonary vein isolation, whether there's effects. And there have been some positive studies, but several of them have been negative studies also. So we're still trying to figure out the best way to ablate these ganglion plexi. But this is one study that was positive in that they found an improvement in being atrial fibrillation free when you had the pulmonary vein isolation and ganglion plexi ablation, as opposed to PVI alone or ganglion plexi ablation alone without PVI. And this is a meta-analysis showing the different studies. And as I said, some of them are favorable, some of them are not so favorable. And so far, we're still looking at finding out how to get more of these that we can have it, the overall results that go more favorable. This is a study that looked at ganglion plexi neuromodulation also, but it was with open chest from surgery. And you may know that after cardiac surgery, many people that had never had a history of atrial fibrillation will have atrial fibrillation after the surgery. And most of the time, we don't know how to manage these very well, except to know a lot of them get put on long-term or lifelong anticoagulation. But we're not sure that that's the right thing to do because we don't have the data supporting that. But anyway, to avoid post-cardiac surgery atrial fibrillation, these patients were given injections into the vent pads of anesthetics or even botulinum toxin. And it seemed to show a favorable result, which in some studies, it wasn't actually favorable or significantly better. But we're still working on those kind of things. I wanted to mention one more mode of neuromodulation. And this is something that I've been doing since I got here to the University of Utah. And I've had a lot of cooperation with the vascular surgeons and with the heart failure service to appropriately select patients for these studies. And it's been very great collaboration, and wanted to thank them for all their support. But in this neuromodulation, we stimulate the baroreceptors, which are on the nerves that are on the outside of the carotid bulb, which is close to the bifurcation of the internal and external carotid arteries. And when you put the electrode there, you tunnel down to the chest. Underneath the skin, you put the generator, and connect it to it, and then start stimulating the nerves. And in doing this, you can help patients with heart failure. And so this is an established, semi-established treatment for systolic heart failure. One thing that this barostimulation does is it restores more normal baroreflex activity, meaning that the sympathetic nervous activity or the sympathetic response in the baroreflex becomes less, and the parasympathetic response becomes greater and more balanced between the two. And so we think this is the main modality that this device has its effect, is by balancing out the autonomic nervous system. And what happens in most of these patients is they have an improvement in their symptoms, and they have a longer 6-minute walk time by almost double. They have a decrease in their New York Heart Association class. And they will have a decrease in their scores on Minnesota Living with Heart Failure questionnaire. And so their symptoms, several times we've shown that those symptoms get better. Even their NT-proBNP is reduced significantly, even more than resynchronization therapy by CRT devices. But what I've seen is these patients, all of them had ejection fractions that were less than 35% at baseline. So that was the criteria that was used in the studies. But in my 8 patients that I've implanted over at the Salt Lake City VA, the EF has improved by an average of 8%. All of them increased a little bit, in fact. And in 2 of them, I had an improvement of 13% and 15%. And those 2, it was pretty obvious that something had happened with their function of their heart, because they had a dramatic improvement in their symptoms and that they were able to do so much more. In one of them, actually, I was having a hard time even getting up to the threshold where I could even have an effect of the barostimulation, where it would even affect his blood pressure or heart rate or anything. But eventually we got to the threshold, I think, and when we sent him off for that last titration of his intensity of his stimulation, he came back the next time and he said, "Whoa, I really felt that. I feel much better." And he was the one that had the improvement of 13%, which is a really great improvement in ejection fraction. When you bring someone up from, 35% up to 48%, you've done a great service to them. You've almost gotten them to normal. The symptoms dramatically improved in all of them. And I guess I have one that's wheelchair bound because of back problems, but I can't really tell with him whether he's had improvement in his symptoms. But a lot of them have less diuretic use, and some of them are off of diuretics now. I wanted to tell you about one patient in particular that I saw that I think we had the most effect on his autonomic nervous system. And he's an 80-year-old male. He has a long history of systolic heart failure, diabetes, persistent atrial fibrillation on amiodarone. He's required cardioversion 3 times. The last time that we did a cardioversion, he went right back into atrial fibrillation a couple weeks later. And he was already on amiodarone, and I didn't think there was much hope that I would ever be able to keep him in a normal rhythm, honestly. He also had orthostatic hypotension, which made it difficult to titrate his medications and to keep him from getting fluid overloaded. It was a very big, difficult problem, actually. So we implanted a barostimulator, and about a month later, and we started to titrate up his barostimulation slowly. And about a month later, I upgraded him to a BiV-ICD, and I didn't get a very good result with my placement of the electrode. Sometimes you're very limited in where you can put the electrode. And I don't think I had any, his QRS was about 135 before I implanted. And when after I put in that LV lead and upgraded him to a CRT device, I think I got up to 132 or something very modest, something that I wouldn't have expected. That, mostly I didn't upgrade him so that I could see if he would get better on his systolic function. That wasn't the purpose. The purpose was I had upgraded him because I had anticipated I was going to pace him 100% of the time because I was going to disconnect him from his atrium. I was going to do an AV node ablation. That was my plan. If I can't control the atrial fibrillation and he's symptomatic with atrial fibrillation, then I'm going to ablate his AV node and make him pacemaker dependent. But now I'm going to pace all the time. And so when I pace all the time, I don't want to pace with a QRS of 180 or 160. I don't want to do that. I want to pace with 135, which is close to what his native conduction was. And so that was my plan. And I certainly didn't get better than his native conduction, which was 135 also. And so anyway, long story short, I upgraded him and I shocked him one more time to see what would happen now that I had him on barostimulation and now that I had the capability of, maybe disconnecting him with an AV node ablation. But I haven't had to think about it again because he's never been in AFib since then. So he actually had a resolution of his orthostatic hypotension also. In retrospect, now that I think about it, he has a history of a gastric bypass, and he lost over 200 pounds. And I think he was suffering from cardiac cachexia. He gained like 10 to 15 pounds, and we worried for a little bit that he was getting fluid overloaded. But I think what was going on is he's just getting more muscle and getting out of this cardiac cachexia. We checked him many, many times after that. We never thought that he was fluid overloaded significantly ever. And his orthostatic hypotension went away. And this is a common thing that happens also with barostimulation, is you will have these patients that are on lots of medications for this systolic heart failure, and most of them decrease your blood pressure. And so you have lots of hypertension, you have lots of orthostatic hypertension, and you can't really control it, and you have to really balance it between how much you can get them on to save their lives and how much symptoms that you give them by the medications that you give them. And what turns out, most of the time with barostimulation, you can actually increase the medications as you increase the stimulation of the baroreflex, because there's a balancing of their nervous system that helps them to be able to tolerate them. And many times that has allowed a lot more medical therapy that is saving lives also. The jury is still out on whether barostimulation saves lives. There is suggestion in the latest study that showed that there possibly was better survival and freedom from an LVAD. But I think we need more studies to sort of prove that. But in this patient, it's definitely helping him, and I'm glad we did it. So, you have any questions?